Cancer of the oral cavity. Cancer of the oral cavity may arise from the lips, buccal mucosa, gums, hard palate, floor of the mouth, salivary glands, and anterior two-thirds of the tongue. Pathophysiology and etiology. Most prevalent in men ages 50 to 70 years, approximately 90% are squamous cell carcinoma. High risk factors are use of tobacco and alcohol, particularly in combination, use of smokeless tobacco, that is snuff, pipe smoking, and chronic sun exposure. Overall, 5-year survival rate is 30 to 40%, depending on the stage of the disease at diagnosis. Clinical manifestations often asymptomatic in early stages. Second, mucosal erythroplasia, red inflammatory or erythroplastic mucosal changes, appears smooth, granular, and minimally elevated, with or without a white component, that is leukoplakia, persisting longer than 14 days. If the cancer in the lips, cancer of the lip, there will be a presence of lesion that fails to heal. Cancer of the tongue, there will be swelling, ulceration, areas of tenderness or bleeding, abnormal texture or limited movement of the tongue. Floor of the mouth cancer, red slightly elevated mucosal lesion with ill-defined borders, leukoplakia, indurated ulceration or wart-like growth. More advanced stages characterized by ulceration, bleeding, pain, induration, and or cervical lymphadenopathy. Diagnostic evaluation. First one, careful inspection of the oral cavity with indirect mirror examination of pharynx. Second, staining of the oral lesion with toluidine blue. Toluidine, toluidine blue. That lesion stains dark blue after rinsing with acetic acid. Normal tissue does not absorb that stain. Third one, excisional biopsy of suspected tissue. Fourth, radiologic studies, chest X-ray, CT and MRI to determine local invasiveness and metastasis. Management. Selection of treatment depends on the size and site of the lesion and how extensively surrounding tissues are involved. Small lesions can be removed by wide excision or treated with radiotherapy or interstitial irradiation. Large lesions may be excised widely or treated by radical neck dissection for extensive lymphatic involvement, followed by external radiation to decrease recurrence rate but maintain appearance. Radiation therapy can be palliative, providing it has not been given previously. Chemotherapy of previously untreated patients with locally advanced tumors has shown high response rates in clinical trials. Complications. First one, second primary cancers of the larynx, hypopharynx, esophagus and lungs. Secondary to treatment, the complications will be, if there is surgery, surgical complications, transient salivary outflow obstruction, infection, voice changes, fistula formation, loss of swallowing, cosmetic defects. Because of radiation, the complications will be temporary loss of taste, xerostomia, radiation caries, osteoradionecrosis. Thank you.